Assalamu alaikum and a very good morning to everyone. I am Dr. H.M. Shariar Rubel and currently I'm working as a lecturer in the Department of Oral and Maxillofacial Surgery, Chittagong Medical College. I'm going to present my research findings on association of cervical lymph node ratio with clinicopathological status of oral squamous cell carcinoma. I'm starting with a brief introduction. Squamous cell carcinoma is the most common neoplasm in the head and neck region and comprises 90% of all oral malignancies. The incidence rate is high. It amongst sixth among systemic cancer and first among head and neck cancer. The management of oral squamous cell carcinoma depends on the status of primary lesion, regional neck nodes, and distant metastasis. Wide three-dimensional surgical excision with neck dissection is still the main protocol of oral squamous cell carcinoma. Several studies have concluded that nodal category, number and size, location of positive lymph nodes, and extranodal extension have increased the risk of regional failure and or distant metastasis. Rationale of this study was, after proper treatment planning, interventions and adjuvant therapy, oral squamous cell carcinomas sometimes presents with local and locoregional failures. Studies have concluded that lymph node ratio is a valuable independent prognostic factor in oral squamous cell carcinoma. So we conducted this study in perspective of Bangladesh to see the association between lymph node ratio with clinicopathological status of oral squamous cell carcinoma. The aim of this study was to evaluate and to discuss the association between lymph node ratio with clinicopathological status as a potential prognostic predictor in patients with regionally metastasized oral squamous cell carcinoma. And the objective of this study was to see the association of different clinical and pathological parameters with lymph node ratio high risk and low risk group. Now come to the method section. This was an observational cross-sectional study conducted in the Department of Oral and Maxillofacial Surgery, Dhaka Dental College, in the period of September 2019 to August 2020. And the population of this study was the operated patients of histopathologically confirmed oral squamous cell carcinoma. And purposive sampling was used, and analysis was done by SPSS. And now come to the inclusion criteria. We have included patients with histopathologically confirmed squamous cell carcinoma, all cases that went for radical surgical resection of the primary tumor with curative intent, together with selective or comprehensive neck dissection. Site of the lesion involved oral cavity, and patient with that will take postoperative radiotherapy and or chemotherapy. And the exclusion criteria included in this study was residual, recurrent, and synchronous oral squamous cell carcinoma, inoperable cases, patient who received previous radiotherapy or chemotherapy, and no signed informed consent. Now, the result section. The demographic and patient's characteristics includes total patients were 53, age ranges from 30 to 60 years and maximum within 51 to 60 years. Female were predominant in our study, and majority were illiterate, and majority were unemployed, and betel quid with chewing tobacco habits were the highest personal habit. This figure shows the T2, clinical T2 size was the highest in number. And this figure shows that the stage 3 was the highest involved clinical staging in our study. Here we can see the grade 1, that is broader classification. It was the highest pre-surgical histological grading. And this figure shows the study patients by number of metastatic lymph node. Here we can see the single ipsilateral lymph node were found as the highest number. In this figure, we can see the Maximum patient has highest lymph node ratio, which is about more than 0.07. Several studies have concluded that a cutoff value of 0.07 to stratify the patients into high risk and low risk group. The patients who had lymph node ratio more than 0.07 are stratified into high risk group, and who are less than 0.07 are stratified into low risk group. This figure shows the status of clear margin, and here we can see the clear margin status was highest in number. And this slide, here we can see the infiltrative pattern was the highest pattern of invasion, and maximum patients had no perineural invasion. And here we can see the lymphovascular invasion was not present in maximum cases. In this figure, we can see the extracapsular spread was not present in maximum cases. So here is the association part. In association, we can see the significance between the following factors with high risk lymph node group. Posterior alveolo-gingival mucosal involvement, grade 2 and grade 3, involvement of single ipsilateral lymph nodes up to 3 centimeter, stage 4, involvement of clear margin, infiltrative in nature, perineural invasion, and extracapsular spread. So in conclusion, we can say that our results highlight the importance of lymph node ratio in association with clinicopathological status of oral squamous cell carcinoma. Although the current TNM staging system has no importance, has no significance of dissected lymph nodes and number of lymph node metastases. So this study demonstrated that lymph node ratio is a valuable parameter to stratify patients of oral squamous cell carcinoma into high risk and low risk group. And also we can see the association between LNR and different sites of oral cavity. These are the recommendations. Here I can say incorporation of lymph node ratio as a prognostic marker in future staging system might help to stratify patients' risk and facilitate the decision for the need of adjuvant treatment modalities. Thank you, everyone.